So innovations in contrast nephropathy is our last topic of the day. You saw all my conflicts, but I'll bring it up again because there are many, many institutional grants for all of the clinical trials that I have in my institution, in our center, as well as some of the important committees that I'm a member of. But important to this talk is the fact that I was the principal investigator of the AVERT study that I will discuss here. But where we are today is that it is important to note that acute kidney injury, while people are saying, well, maybe it's really going away, it's still kind of common. It's about 6 to 10% of our procedures. It's expensive and it is associated with a high morbidity and mortality. I hope that that is a well documented now based on several clinical trials showing the very important impact of contrast-induced acute kidney injury or acute kidney injury after a procedure. It may or may not be all related to contrast, and that's something that we're going to be discussing, but very important to see the very close linear relationship to death, myocardial infarction, and bleeding. Very, very interesting association. Although it may not be causal, it certainly is something to think about because it increases costs, and hospitalizations associated with acute kidney injury is very, very high cost. This is just in the British Medical Journal looking at the European costs, but it's very, very similar in the United States. And of course, in our current armamentarium, we're very, very closely thinking about this, and the current guidelines, class 1 indications, is to assess the risk of the patient, make sure that there's preparatory hydration, and basically minimizing the volume of contrast media. So really, much of the innovation is basically around these 3 areas: screening for the patient, hydrating the patient, and reducing your contrast volume. That's all you need to do at the moment to try to reduce acute kidney injury. So identifying the high-risk patients, there are a slew of risk scores out there. Of course, I put mine on the top, so you all use mine, but there are several excellent risk scores. There's the NCDR has one, Dr. Gurm has one, Tom Tsai has one, and of course these really are very, very easily approachable. But let me just say, despite the fact that we have a lot of risk scores, these are not being used as much. And the fact of the matter is that we have to, in order for a risk score to be used, we have to use it and then show that we're able to actually reduce. So the validation of reduction of acute kidney injury hasn't been shown using these important risk models. But at the very least, we could identify who's at higher risk. And all of those patients that are at higher risk, and I would argue that all of the rest of them should be hydrated before they come to the cath lab. And it is very, very important, because no question that when you have a well-hydrated patient, you decrease the contrast concentration in the filtrate that goes to the kidney, you decrease oxygen consumption in the medulla because to decrease the sodium reabsorption. And it's very, very important that you actually decrease oxidative stress, and all of these have been shown. What prophylactic hydration work should be done? And it was very interesting. This study, the Amazing study, was not amazing to me at all. They did hydration versus no hydration in about 600 patients and only had a 2% no difference. So in this particular study, in the Lancet, they showed that you didn't need to hydrate people because you could leave them without hydration, and all of these patients had eGFRs between 30 and 60. But it's very important to note this is a single center study, 16% only PCI cases, low event rates, which tells me ascertainment was not good, and of course, very important that 65% of the patients had their serum creatinine between days 2 and 4 post-procedure, and we know that there's a lot more happening beyond that. What IV hydration protocol you should do? There's good work that says really very important to do 3 mils per kilo over an hour, or 1 mil per kilo for 1 to 3 hours. Hold for severe valve disease or severe congestive heart failure, and using the LVEDP could be an important way, and this was through the Poseidon study, a very innovative approach by Sam Brar, where he actually used an LV end diastolic pressure at the time of his intervention to guide his hydration. Based on that, he used different rates based on what the LVEDP was, and just with that, he was able to reduce 60% rate of acute kidney injury from 16% down to 7%. The most recent study that looked at the different hydration strategies and N-acetylcysteine is the largest trial performed by Stephen Weisbold and colleagues in close to 5,200 patients, where they were randomized in a 2x2 factorial design to N-acetylcysteine, bicarbonate, sodium chloride, or N-acetylcysteine and placebo. And very, very interesting to note that none of these made a difference. So sodium bicarbonate N-acetylcysteine is really out as any kind of a preventive strategy. Primary endpoint was totally negative, about 4.5% or so of contrast-induced acute kidney injury, and no difference at all between the two arms, or the whether it was sodium bicarbonate versus sodium chloride, or N-acetylcysteine versus placebo. No significant differences with multiple comparisons. Finally, we have a really nice meta-analysis by Giacopo that actually is looking at all of these things, showing, interestingly, that statin administration is associated, based on all of the data that's out there, with some reduction of acute kidney injury, and that there are some hypotheses that perhaps N-acetylcysteine, sodium bicarbonate, or the two of them together may be nephroprotective. There's no evidence at all that it works whatsoever. Minimizing contrast media use and the volume is very important, especially for the CTO operators who are using large volumes of contrast media. This is one of the few modifiable risk factors, and we note that there is a correlation, and an important correlation, between renal function based on contrast dosing and what happens in acute kidney injury. There's no question that there is important correlation there. There is a new system out there that should reduce contrast media volume by having a contrast modulator, and this modulator reservoir takes over and takes the extra volume of the contrast media out that is not being used in an injectable way. I'm going to show you how it works exactly, but in this 578 patient study comparing a VERT system to control, we were able to reduce contrast media by 15%, and although there was no association with the reduction of acute kidney injury, there was some association with the most complex of those patients, with some trend towards reduction of acute kidney injury. The divert system is the more next generation device here. Here, a pressure compensating valve adjusts the resistance in the diversion line. And there is this reservoir chamber that temporarily stores the diverted volume of contrast and then gives it back, so in your next injection you don't lose the system. So if you could see what's happening here, this is the system. It's attached to the catheter. You aspirate the way you would normally. During injection of the contrast, the excess gets diverted up into that reservoir. As you're injecting, the excess goes up into the reservoir after the coronary is filled based on the pressure reservoir that it is seen, and then the extra comes back again into the syringe for your next injection. With this system, in a 96 patient study, they were able to show a 40% reduction in the contrast volume without any change in the imaging that you were watching. So there are innovative ways to be able to reduce your contrast media, and it really is a volume, and it's very, very important to actually watch out for that. So if you want to prevent acute kidney injury, assess the patient for the risk, hydrate, minimize the use of contrast volume, and actually monitor that really, really closely. Thank you for your attention.
Roxana, maybe I'll start off with a question for you. You know, John Biddle years ago said, you know, why are we keeping patients NPO for hours on end before a cath procedure? And he was really worried about the diabetic population, but I think it applies to everybody. How much do you think our restricting PO fluids plays a role here? We hydrate people ahead of procedures, but I don't imagine for a minute that we get them back to euvolemic status, which is where what they would be in if we allowed them to walk into the lab taking PO liquids normally till, oh, I don't know, an hour or two before the procedure. Do you think there's something there?
Yeah, there's no question that we're now changing our entire, so we look at the, every morning we look at our plan, the morning patients obviously, and the ones that we know are the second and third case, they get to eat their breakfast. Some of them get a full lunch if they're going to go after 3 p.m. And we are really working very, very hard to make sure. And at the end of the day, we always, a lot of this is helping the contrast-induced acute kidney injury, but frankly, it's helping the experience of the patient not to starve and not to be hungry and thirsty before a procedure, and that always reminds them, and they don't want to come back. So there's no question that the simple measure of just giving them oral hydration until a couple of hours before the procedure is a great way to, and a very innovative approach.
Simple.
Simple.
I like it.
So
Yeah.
Kirk, we've stopped keeping our right heart cath patients NPO about a month ago, and we just give them, if they needed, a little bit of Valium for their sedation. So I'll let you know in a year whether the average pulmonary capillary wedge pressure, that there's
Goes
real
down.
weakness has gone up now that people are not NPO anymore.
So, any questions from the audience at all? I promised, I think this was an amazing session, Manos. Thank you for putting this together. We talked about the unmet needs, and then we went on to talk about stents, imaging, pharmacology, access, and all the innovations that are happening. But of all of those, I think we have to vote. Which one is the one that's really, really hot? And I think that's the one that is going to make the most difference in the outcomes of our patients. Do you think it's pharmacology? Not this crew.
I don't know, that might get my vote.
I think it might get mine too.
I liked what you had to say a lot, Duane, about the acute care pharmacology. I mean, very thoughtful approach, and we're all evolving through this. Some of it's going back to the future, some of it is learning how to use newer compounds effectively. The truth of the matter is, though, it's very expensive to develop drugs. The timeline for getting them developed is very long. For those reasons, it's always a very slow motion affair. I wonder if there wouldn't be some way that we could expedite that process. Probably not, but wouldn't that be great if we could turn over a novel drug concept in 24 or 36 months rather than 8 or 9 years?
I think the idea that we're going after a different target outside of the platelets, and going after the PCSK9 and going after inflammatory biomarkers and all of that is going to be very, very interesting. But the innovation in stenting is pretty tremendous. There are so many different stent technologies. Is that going to make a difference, do we think? Or is it, we didn't talk about wire technologies, which I think are probably the most innovative. Probably I would vote for you to add that next year to this group of things. Yeah. So innovations in CTO, wire technology, and then the other one is to the calcific lesions and how we're preparing our most complex lesions for the best possible therapies.
You know, under the wires, there's a really interesting product available in Europe. There's an effort to bring it to the U.S. now. It's produced by a company called Nano for Imaging. It's a group of engineers that are looking at not just MR compatible wires, but specifically MR purpose-made wires. They thought, look, we're all, I think pretty much everyone in the room is an adult interventionalist. What about these kids, pediatric population?
The person is an adult, or because we don't always act like adults.
We don't act like adults, so it's hard to measure, but our patients do. This group said, gosh, what about the pediatric population? These little kids can get a ton of x-ray in the first year of life. Wouldn't it be great if we could just do something like a right heart cath without having to put them under a fluoroscope? And so they're developing a portfolio of equipment that is hopefully going to get us there and could one day have application for even the adult population.
So no contrast is another one where we could image without contrast, and I didn't talk so much about that, but certainly zero contrast, I think, to me is extremely innovative. But I worry about those very long procedures that Ziad Ali is doing in these CKD patients. But also, I think no radiation. What are we doing to reduce radiation? Is it robotic, sitting outside the room? I don't know about that. I don't know. I don't see. I think it's very interesting. I'm really kind of interested in that. But I think we need to protect ourselves. You had a last
I was
comment.
just going to say, from my experience, the innovation in my practice has been with the complex PCI and the mechanical support, just opening up that whole new realm of those patients and challenging patients, for surgery. Is that truly they really need to have bypass? Can we do this better, safer, easier recovery?
I think there's no question that hemodynamic support, especially the Impella device, has been so incredibly forceful in helping us to handle. I mean, the fact that we could just really, in a very nice, non-stressed environment, take care of the most difficult cases because there's a heart pump working and protecting the patient is tremendous. I think there's no question about that. That's probably one of the most effective and interesting areas that we are working on.
So Roxana, to answer your question of which of these, I say yes to all of them because it's a different definition of best for innovation. I mean, the pharmacology is going to affect everybody. So there's numerically more patients any innovation is going to affect. The stents and the complex procedures is a subset of populations, but it is a group of patients that had nothing for us to offer before. And along those lines of the Impella patients, the CTO techniques and the devices that we use, there's been a renaissance in what we can do in the last 5 years.
Tremendous. And that's why this meeting is so important. And thank you all for being here and sticking it out all the way till 5 p.m. But keep innovating and keep thinking outside of the box, because our subspecialty that's so dear to all of us and we love it so much is thriving on innovation. Thank you so much for being here.